Thank you. All right. Thank you so much for the kind introduction, Dr. Murillo, and morning, everyone. Thank you for tuning in. So it's my pleasure to present Grand Rounds this morning, and I'm very excited to discuss this topic, point of care ultrasound applications in cardiology. It's one that I think is a very broad topic and one that's been a bit controversial in our discipline. But I hope with my perspectives as someone who was first introduced to point of care ultrasound as a medical student and has subsequently completed formal training in echocardiography as well as critical care training using ultrasound in a critical care setting, I can offer some of my perspectives and stimulate some discussion about where I think this field is going. I have no disclosures relevant to this talk. So this painting depicts a key moment in medical history. Dr. René Laennec, a French physician in 1816, had the insight to roll a quire of paper into a cylinder, which enabled him to hear the heart sounds of a sick patient instead of placing his ear directly on the chest. So with this insight, Dr. Laennec triggered a revolution in diagnostic clinical medicine. His insight led to the invention of this device, which we're all intimately familiar with and has changed very little in 200 years, the stethoscope. Now, Dr. Laennec coined the term stethoscope from the Greek word stethos, meaning chest, and scopen, to look inside. But I'll argue to you today a little bit that this device may not be actually appropriately named, and what we call a stethoscope is truly a stethophone, that is a device to listen to the sounds of the body. In 2022, rapid technological advancement in ultrasound technology have created new devices that allow us to truly see inside the body. And I believe that these new ultrasound devices will allow us to truly peer inside the body and are leading to a new revolution in diagnostic clinical medicine, just as the stethoscope did in Dr. Laennec's day. Point of care ultrasound, a recent review in the New England Journal of Medicine defined the technique as the acquisition, interpretation, and immediate clinical integration of ultrasonographic imaging performed by a treating clinician at the patient's bedside, rather than by a cardiologist or radiologist. I think this statement sums up a point of care ultrasonography quite nicely, but I'll have to disagree a little bit with Dr. Diaz-Gomez, Mayo, and Koenig in that I think cardiologists actually have a significant amount to gain from the use of point of care ultrasound. But what this statement really says is that cardiologists and radiologists have mainly been involved in consultative ultrasound, wherein the imaging is performed by a technologist and later interpreted by the specialist imaging physician who provides a report to the clinician. The origins of point of care ultrasound, I think, really start in the field of emergency medicine, where emergency doctors started to use ultrasound in blunt abdominal trauma to identify the presence of free fluid in the abdomen. For example, here we can see this anechoic stripe in the hepatorenal space, indicating the presence of free fluid in this setting, meaning blood. And the focused assessment of with sonography for trauma, the FAST exam became a fundamental tool in the ER. And I think this really became a catalyst for emergency physicians to start using ultrasound in other applications relevant to their practice, starting in the 90s and evolving forward from there. Another discipline that pioneered the bedside use of ultrasound was intensive care medicine. This is Dr. Daniel Lichtenstein, who is considered the father of lung ultrasound and who pioneered whole body ultrasound techniques in the ICU. There's been a rapid increase in the research related to point of care ultrasound, and the number of publications now exceeds more than 17,000 in my recent search, particularly in the last 10 years. So there's a rapid uptake in this field and a significant amount of progress that's occurred. Now, although point of care ultrasound is not defined by the machine that is used, there's been a significant advance in the devices that are available to us. And I think just as Dr. Leniak's stethoscope facilitated auscultation, these new ultrasound devices will facilitate the expansion of point of care ultrasound. This is an example of some of the handheld devices that are now available, which have increased diagnostic and imaging performance, improved battery life, ease of use. They routinely incorporate B mode, so 2D imaging, as well as color Doppler, and now have additional functions that include the ability to have wireless communication, facilitating the archiving of images, and are small enough to fit in a lab coat. Additionally, the price of these devices continues to decrease, facilitating wider uptake. Point of care ultrasound is now being integrated into medical school training. So this document, published a few years ago on the Canadian medical student ultrasound curriculum, was led by Dr. Irene Ma, who is at the University of Calgary and is a Canadian leader in point of care ultrasound education. And this group from across Canada proposed a set of fundamental ultrasound skills that can be taught to medical students. And now in medical school, a lot of students are introduced to ultrasound during their anatomy lectures or physiology. So it's being integrated, and a new generation of physicians is going to be native ultrasound users moving forward. So point of care ultrasound really took off in the fields of emergency medicine, starting with the FAST exam and in the intensive care unit. But since then, with development of medical school education, there's been an explosion of uptake of specialty-specific point of care ultrasound in different medical specialties. So some examples here, POCUS for obstetrics and gynecology, hematology, anesthesia, nephrology, GI, and hospitalists and general internists. So each of these disciplines has found specialty-specific uses for this technology, and really, I think this is what's pushing the field forward. But I think this type of specialty-specific focus so far has been missing from cardiology. We've been using ultrasound in the traditional consultative way in the echocardiography lab, but I think the uptake and the true potential of point of care ultrasound in cardiology has been yet to be achieved. So what I hope to do for the remainder of this talk is to highlight some of the use cases of point of care ultrasound in cardiology. And some of these will be more established techniques, and others I hope will plant some seeds and provide some interest as to how this technology might evolve in our specialty. So of course, when we talk about point of care ultrasound, one of the fundamental and key organs to image is the heart. And the heart is actually probably the most difficult organ to image. It requires the greatest degree of training and expertise to interpret the ultrasonographic images. Point of care ultrasound of the heart is actually, the preferred term is focused cardiac ultrasound. So when non-cardiologists perform focused cardiac ultrasound, they're really looking at a set of limited diagnoses. For example, the presence or absence of a pericardial effusion, the gross left ventricular function, and things like this. But I think in cardiology, focused cardiac ultrasound has significant potential. The questions are, why would we use this, and when could we best apply this technique? So as cardiologists, we undergo rigorous and detailed training in the bedside cardiovascular physical examination. So why would we need ultrasound to augment our physical exam techniques? Well, I think this is a landmark paper that really highlights the limitations of physical examination. So basically, in this study, the diagnostic accuracy of 2 medical students with 18 hours of training in cardiac ultrasound was compared to that of 5 board-certified cardiologists who performed physical examination techniques. So the medical students and cardiologists each sequentially and blindedly examined 60 patients and wrote down their diagnostic findings. And as you can imagine, the medical students with ultrasound significantly outperformed the cardiologists. This bar graph shows the sensitivity and specificity of the findings for valvular lesions, systolic murmurs, and diastolic murmurs of students in black and cardiologists in white bars. And in particular, the ultrasound enhanced students' diagnostic sensitivity to detect cardiac lesions. Cardiologists had pretty good specificity, but significantly missed important diagnoses. So I think the physical examination, although it's been a technique that we've relied on for 200 years or more, has significant limitations that ultrasound can enhance. So what happens when cardiologists use these small portable devices in the clinic setting? So this paper, published over 10 years ago, described the use of a handheld ultrasound machine in patients referred for echocardiography. Now, unlike the previous study, these ultrasounds were performed by trained cardiologists, and the findings were compared to a full echocardiogram done with a cart-based system and a sonographer. And what this study showed is that even with a small handheld ultrasound with limited screen resolution and only having 2D and color Doppler modalities, cardiologists had significant accuracy. So this is an example from the paper showing the ejection fraction estimated by the handheld ultrasound on the y-axis and the high-end ultrasound system on the x-axis, showing a significant correlation, and a Bland-Altman plot of visually assessed ejection fraction, demonstrating minimal bias and standard deviation, or 95% difference. So cardiologists can achieve significant diagnostic accuracy comparable to a formal echocardiogram in many domains, even using a small handheld system. A more recent paper used another, more recent handheld ultrasound device to screen for native valvular heart disease. Again, in this study, trained cardiologists performed the examinations on 300 patients and looked for significant valvular heart disease. They also performed physical examination to determine the sensitivity of the physical exam technique. And again, physical exam was limited. Only 50% of the valvular lesions were identified correctly by physical examination. However, using a basic handheld ultrasound with only 2D imaging and color Doppler, cardiologists were able to identify 100% of the significant valvular heart lesions. So I think what these studies show in aggregate is that the physical examination has significant limitations, and that the use of ultrasound in the clinical setting, even with a small handheld device, can add significant diagnostic information. So a medical student might start off with a limited physical exam, augmented with ultrasound may exceed that of a cardiologist, but starting from a more advanced baseline, the addition of ultrasound can lead to even greater diagnostic accuracy. So these small handheld devices have significant potential for use in the clinic setting, where they can be portable and readily applied. Another cardiac ultrasound, point-of-care ultrasound domain that's emerging is that of critical care ultrasound. And I think it's important to recognize the value of this tool in the emergency setting in the cardiac ICU. Now, so far I've been discussing mainly the utility of handheld ultrasound machines, and I want to pause for a minute to describe these ultrasound machines that are tailor-made for ICU use. So these machines are cart-based, but unlike a full echocardiography machine, are smaller and more portable, easier to clean, have a faster start time, and have multiple probes which allow for full body assessment. When looking at the cardiac performance of these ultrasounds designed for ICU use, they can actually perform a comprehensive echocardiogram. They have full spectral Doppler and tissue Doppler modalities that allow for advanced hemodynamic assessments. So the advent of such ultrasounds has really facilitated the growth of critical care ultrasound. And recently, the National Board of Echocardiography has recognized critical care ultrasound as its own subdiscipline and created a certification examination in critical care ultrasound, which is really focused on the use of cardiac ultrasound in the ICU setting, integrated with additional body imaging such as lung ultrasound. So how might we apply bedside ultrasound in the emergency setting when an echocardiogram is not readily available? This study, published in Critical Care in 2021, examined the use of POCUS during ward emergencies in a prospective observational controlled trial. So they used a standardized protocol for patients with circulatory failure, assessing left ventricular function, right ventricular function, and pulmonary assessment to rapidly come to a diagnosis based on ultrasound findings. Patients were randomized to a control group, so 82 patients underwent standard clinical assessment without ultrasound, and 83 patients underwent POCUS evaluation. And the POCUS group had a significantly greater rate of an immediate adequate diagnosis, so 94% of these patients, compared to only 80% of the standard group who had an immediate diagnosis. In the setting of an emergency, this immediate diagnosis is critical. And in this study, actually, there was a difference in mortality between these groups. So 35% in the control group versus 17% in the POCUS enhanced examination group. Now, this may have been driven by the fact that the more rapid diagnosis in the POCUS group led to more rapid initiation of treatment. So this occurred in 15 minutes in the POCUS group versus 34 minutes in the control group. Another domain where I think bedside cardiac ultrasound has enormous potential is during the evaluation of cardiac arrest. So obviously in cardiac arrest, this is an emergency and there is not an availability for formal echocardiography. And here we can see a transthoracic image of the heart demonstrating ventricular fibrillation, which can be identified based on the quivering appearance of the myocardium and mitral valve. Transthoracic echocardiography can potentially be used to identify reversible life-threatening conditions during cardiac arrest, particularly during pulseless electrical activity. Here, for example, identifying cardiac tamponade, or here signs of right ventricular strain consistent with a pulmonary embolism. Now, although transthoracic echocardiography has a lot of promise in this field, there are also significant limitations that we have to consider. Number one, not all patients will have adequate echo windows. Number two, transthoracic echo can only be performed during the pulse checks, and it's critically important that it does not prolong the pulse checks, as that will lead to inferior resuscitation outcomes. A modality that's emerging is actually point of care transesophagealechocardiography. So obviously this is an advanced technique that could be used in the cardiac ICU to facilitate resuscitation. Advantages of TE, as described in this JACC review, include an ability to image the heart continuously during resuscitation and without the limitation of surface windows. So we can potentially use transesophagealechocardiography after a patient is intubated during a cardiac arrest, and often it can be deployed within 5 minutes if it's in the unit which is set up to do so. So using TE, you can identify the underlying cause of the arrest, but also, because you're not limited to imaging during pulse checks, you can use TE to identify the quality of CPR. So here you can see poor CPR, and here with an adjustment in the position of CPR, there's an improvement in left ventricular compression. You can actually see aortic valve opening occurring during CPR. So a preclinical study that evaluated TE-guided CPR in a pig model showed improved ROSC when CPR was optimized using transesophagealechocardiography. So from the clinic setting, using small handheld devices, to the cardiac ICU, I think there's significant potential for the use of focused cardiac ultrasound in cardiology. Next, I want to discuss the use of lung ultrasound. So if we move beyond the heart, I think lung ultrasound is an incredibly promising area that is starting to become more recognized in cardiology as a useful adjunct. These two review articles provide a useful primer for cardiologists on how to use lung ultrasound. And compared to bedside cardiac assessment, lung ultrasound is actually relatively simple. So this image shows the fundamental view of lung ultrasound. We can identify the subcutaneous space and the ribs, which cast shadows. And the lung, which is predominantly comprised of air, creates reverberation artifacts of the pleural line, which are known as A lines. Additionally, normal lung architecture includes the presence of lung sliding, which is a shimmering artifact caused by the apposition of the visceral and parietal pleuras. So one of the challenges of lung ultrasound is, where do you image? And I think what's really become clear is that a simplified imaging protocol is appropriate. So this is an example of the blue protocol developed by Dr. Daniel Lichtenstein in the ICU, which basically uses a 6-point anterior and lateral chest assessment. So there's 2 anterior points where lung ultrasound is performed, as well as a lateral point. And this simplified protocol has excellent diagnostic performance and is comparable to more complex protocols, such as a 28-point assessment that's been advocated. So using a simplified protocol and an ability to understand a few basic lung ultrasound findings, you can start to make significantly useful diagnoses using lung ultrasound. And I want to focus in on one particular lung ultrasound finding that I think is important in cardiology, and that is the presence of a B line. So the B lines are these linear artifacts that emanate from the pleural line into the far field and basically erase the horizontal reverberation artifact A lines. Essentially, B lines are caused in the appropriate clinical setting by increased extravascular lung water. And you might think of them as lung ultrasound equivalents of chest X-ray curly B lines. What's useful about B lines is that there's a graded effect. So a lung with normal aeration will have no B lines. A lung with subclinical congestion will start to show a few B lines. And as the content of extravascular lung water increases, as pulmonary edema gets worse, the B lines will become more confluent, eventually leading to a consolidated lung. This meta-analysis assessed the diagnostic performance of chest radiography compared to lung ultrasound in the assessment of acute decompensated heart failure. And the finding was that compared to chest X-ray, lung ultrasound actually had superior diagnostic performance. Basically, this was driven by improved sensitivity of lung ultrasound for detection of pulmonary edema without compromised specificity. So even compared to chest X-ray, lung ultrasound might allow us to detect pulmonary edema at an earlier stage. What about the utility of lung ultrasound in patients with heart failure in the clinical setting? So this paper published in JACC assessed the prognostic value of lung ultrasound using a simplified 4-zone scanning protocol. B lines were quantified on admission and at discharge. And the key finding of this paper was that patients who had an increased number of B lines at the time of hospital discharge had worse outcomes compared to those patients who had fewer B lines. So this suggests that B lines might be a marker of pulmonary congestion that we could target to impact on outcomes. And just recently, a randomized trial was actually published assessing the value of heart failure therapy guided by lung ultrasound compared to standard clinical assessment. So this was the cluster heart failure study. It was a small randomized trial performed at a single center. Patients were followed in the outpatient setting after a heart failure admission, and they were randomized to a lung ultrasound guided group versus a conventional control group. Now, patients in both groups underwent lung ultrasound. However, only physicians in the lung ultrasound group were unblinded to the lung ultrasound findings. These patients were followed for a total of 6 months with 4 pre-specified visits. Now, what was found is that the patients in the lung ultrasound group had fewer heart failure visits, rehospitalizations, and deaths. And now this outcome was predominantly driven by heart failure visits, but it's a small trial, and I think this is a very promising result. So the difference was really driven by the detection of subclinical congestion. So patients in the lung ultrasound group had an increased prescription of diuretic doses and consequently had a greater reduction in NT-proBNP. And what was encouraging also is that this occurred without an increased incidence of acute kidney injury or hypokalemia in the lung ultrasound setting. Let's move on to examine the potential utility of abdominal ultrasound in the cardiology setting. So Abdominal ultrasound can be performed to assess the abdominal organs. So these are the standard views of the right upper quadrant, suprapubic zone, and left upper quadrant, which allow us to examine the kidneys and the liver, the bladder, and the spleen. And also, these are the views used in the FAST exam to detect free fluid in the abdomen. But I think what a more interesting and more pertinent application of abdominal imaging in cardiology would be is the detection of systemic venous congestion. So here we can see images of the inferior vena cava, and the diameter of the IVC, as we all know, can be used to estimate central venous pressure and has actually significant prognostic value in patients with heart failure. But one area that I'm interested in is actually a more advanced assessment of systemic venous congestion that can be performed using Doppler ultrasound. So I'll touch a bit on my research using POCUS to assess renal hemodynamics. Now, this type of study is not performed with a handheld ultrasound machine. It would be performed with one of the more advanced cart-based machines that has pulse wave Doppler capability. What we're looking at here is a kidney in coronal view, and color Doppler highlights the renal parenchymal vessels. By placing a pulse wave Doppler sample on the renal parenchymal vessels, we can obtain a hemodynamic tracing of the blood flow in the kidney. The flow above the baseline is arterial flow towards the probe, which is towards the renal cortex, and the flow below the baseline is venous flow of blood draining out from the kidney. This venous flow pattern in this instance is normal, and it shows a continuous flow pattern of venous blood leaving the kidney. So this intrarenal Doppler pattern changes in patients with heart failure, and particularly the venous side is of interest. So as patients with heart failure experience worsening congestion or are subjected to volume loading, the continuous venous flow becomes phasic and can even become discontinuous. So in this case, we can see a discontinuous biphasic flow pattern of venous blood flow. And even worse, congestion leads to a monophasic flow pattern. So this assessment of renal hemodynamics with Doppler ultrasound is highly sensitive to congestion and may be a useful biomarker in heart failure. And indeed, in 2016, this study published in JACC demonstrated profound prognostic value of these renal Doppler flow patterns. So patients with continuous venous flow had good outcomes, whereas patients with biphasic flow and monophasic flow had significantly increased rate of cardiovascular death and unplanned heart failure admission. Now, renal congestion is potentially one of the key pathophysiologic mechanisms of cardiorenal syndrome, which complicates up to a third of heart failure hospital admissions. So I studied the impact of intrarenal Doppler assessment as a potential cardiorenal biomarker. So I want to talk a bit about that study that I performed during my cardiology fellowship. So basically what I did was assess the renal Doppler pattern in patients with acute decompensated heart failure at the time of hospital admission. And in this small pilot study, I studied 21 patients with heart failure. And I used a novel quantification method for renal Doppler called the renal venous stasis index. So basically looking at the duration of venous flow compared to arterial flow and quantifying the no flow time. So patients with monophasic flow pattern would have an increased numeric value of renal venous stasis index. So the no flow time increases. In a patient with normal continuous flow, the renal venous stasis index would be 0 because the venous flow is continuous. So in this figure, when we look at the change in creatinine during hospital admission as a percentage from baseline plotted versus the renal venous stasis index, we can see a significant positive correlation between increasing renal venous stasis index and the incidence and severity of acute kidney injury during heart failure hospital admission. We did not see similar associations with echocardiographic estimated cardiac index, right ventricular function as assessed with TAPSE, or creatinine change compared to mean arterial blood pressure. So again, I think this advanced POCUS evaluation of renal venous blood flow might be a useful biomarker of cardiorenal syndrome and heart failure prognosis. A group from Quebec, led by Dr. Andre Deneau, has actually validated a similar technique using point-of-care ultrasound to grade venous congestion using Doppler techniques. So Dr. Deneau's group has combined intrarenal Doppler, like I performed in my study, with assessment of portal vein Doppler and hepatic vein Doppler flow patterns. And what they do basically is grade the severity of abnormality in each of these vascular beds on the venous flow side to come up with a summary score of the venous congestion severity. And like I found in my small pilot study, this group found that the venous excess ultrasound score significantly predicted incidence of acute kidney injury among patients with post-cardiac surgery setting. Another domain that I think point-of-care ultrasound has significant potential is that of vascular ultrasound. So we can look at numerous vascular beds to come up with some useful diagnostic information. So this image demonstrates a couple of things that we're all familiar with. So the carotid and internal jugular, or the vein, which would be typically seen during a vascular access procedure, as well as the abdominal aorta, which is part of the standard echocardiographic assessment. So ultrasound has become standard of care for central access and vascular access procedures. But I think these two studies are actually really important to consider and demonstrate that even in the cardiac catheterization laboratory, ultrasound is a key tool that can enhance our procedural success. So the FAUST trial in 2010 randomized 1,000 patients in the cardiac cath lab undergoing femoral access to standard fluoroscopy technique versus ultrasound guided technique. And the ultrasound guided technique resulted in 83% first pass success versus only 46% first pass success with fluoroscopy. Additionally, there was a reduced time to access and a significantly lower rate of vascular complications at the femoral site in the ultrasound group. More recently, in 2015, the Rouse trial examined the use of ultrasound-guided radial artery access and demonstrated, again, an increased first pass success rate with a median of 1 attempt for ultrasound versus 2 attempts for manual palpation, and reduced time to vascular access. So I think this is really telling that even among physicians who are the most experienced in vascular access, that is interventional cardiologists, ultrasound really facilitates procedural success. And when procedural complications of vascular access do occur, there is a potential for ultrasound to be used to detect them. So this is a case report using point-of-care ultrasound to identify the presence of a femoral AV fistula, which is basically characterized by the presence of a yin-yang sign of swirling blood flow. So, I think this is an area that warrants further study, is whether POCUS can be used to screen for vascular access complications in patients who've been subjected to femoral vascular procedures. Another potential use is the screening for atherosclerosis. So this is a really interesting paper published in 2016 that used point-of-care ultrasound to assess for carotid atherosclerosis. This was led by Dr. Amer Jory, who's a cardiologist based in Kingston, Ontario. And basically they developed a limited carotid scan protocol to assess for the presence of atherosclerosis in the carotid bulb. So this was a simple scan, basically, that looked at the maximal dimension of atherosclerotic plaque in the carotid bulb. They assessed this in patients who were referred for coronary angiography and found that patients with significant coronary artery disease had a much greater incidence and much greater thickness of carotid atherosclerosis. So this technique had a very high sensitivity for predicting presence of coronary artery disease, and maybe a useful biomarker for atherosclerosis that could be applied in a clinic setting. This would require, I think, some further study. Another technique that we use with physical examination is the carotid sinus massage, but I think ultrasound can really facilitate the safety and efficacy of this procedure. So number one, we can use ultrasound to exclude the presence of significant carotid atherosclerosis. And number two, ultrasound might actually facilitate a superior vagal response by targeting the point of compression. So in this pilot study, ultrasound-guided carotid sinus massage actually changed the point of compression by 1 centimeter and led to a more significant or a larger reduction in heart rate compared to a standard palpation technique. Another vascular point of care ultrasound application is assessment of the abdominal aorta. So this is something that we look at in consultative echocardiography, but I think there's significant potential for us to improve the examination of the abdominal aorta with ultrasound. And this is something that I think that's been really studied well in the emergency department literature, where a meta-analysis has shown excellent diagnostic performance of emergency physicians to detect abdominal aortic aneurysm. So sensitivity of emergency physicians was 99% and specificity 98% to detect the presence of a significant abdominal aortic aneurysm using point of care ultrasound. So this is, potentially critical diagnosis and something that we could easily pick up in the clinic setting with a bedside scan. Assessment of the aorta can also be, can reveal other findings such as presence of pseudoaneurysm, atherosclerotic plaque, penetrating ulcer or dissection flaps. So these are things that are easy to see and could have significant implications for patient care. And finally, point of care ultrasound can facilitate the bedside diagnosis of deep venous thrombosis. So in this image, we see the femoral vein and the femoral artery, and you can visualize an echogenic thrombus in the femoral vein, which upon compression prevents complete obliteration of the venous lumen. So a bedside ultrasound technique that relies on compression of the femoral vein can have a very high sensitivity to detect DVT, as shown in the emergency department literature. So simply scanning at the femoral vein and at the popliteal vein using a 2-point compression technique has comparable diagnostic performance to formal radiology department ultrasound scan. Sensitivity 91% and specificity of 98%. So I think what we can start to envision is an application of point of care ultrasound in cardiology that really can enhance our evaluation of the cardiac patient. So starting with focused cardiac ultrasound applications that really apply in the clinic setting and in the cardiac ICU, and moving the ultrasound probe to look at other organs such as the lungs, the abdomen, and the vasculature can really start to give us a comprehensive picture of the cardiac patient and really provide us with a new way to examine patients in the 21st century. One question is, what are patients' perceptions of ultrasound technique in the clinic setting? It's possible that, ultrasound, involving gel and compression might be perceived negatively by patients, but this study, which assessed the use of point of care ultrasound in general practice settings, surveyed approximately 600 patients on their perceptions of GP use of ultrasound to enhance clinical examination. And the findings were profoundly positive. So patients basically felt that they had been more thoroughly examined. They increased the ultrasound use, increased the trust in the physician assessment, provided them with a better understanding of their health conditions, made them feel more secure. So I think in this era of increased telemedicine use, there's a real potential for point of care ultrasound to bring patients back to the clinic and to help strengthen the doctor-patient relationship. So I've spoken a lot about point of care ultrasound and how this is going to change everything in cardiology, but I think it's really important to emphasize that POCUS will not replace consultative echocardiography. In parallel with the advances that we've seen in handheld ultrasound techniques and cart-based techniques and research, there's been an explosion of new techniques in formal consultative echocardiography, including three-dimensional echo, advanced visualization techniques, strain imaging, and contrast imaging. So the role of the echocardiography lab is not going to go away. And also the role of medical sonographers, who really are experts in diagnostic imaging, is not going to go away. And the echocardiography lab will remain as the gold standard, where findings that are detected on POCUS are going to be clarified and fully evaluated. So, I think the future of cardiovascular POCUS is bright. I think there's going to be continued improvements in the technology. We're going to see further reduction in cost of handheld devices, improvement in performance. There's going to be integration of artificial intelligence analytics that will facilitate diagnostics and measurement and increase the ease of use of point of care ultrasound technologies. We're going to also see an increase in cardiology specific POCUS research. I think, some of these techniques are still in their infancy and there have been small pilot studies, but I think certainly more work remains to be done about how these tools can be used to really change clinical care in the cardiology setting. And I think we need to have more standardized training and maintenance of competence. So we're seeing medical students being trained in ultrasound, but I think this training really needs to continue throughout, internal medicine residency and also in cardiology fellowship to establish, bedside ultrasound techniques for cardiology use. So in conclusion, I think the physical examination of the 21st century is going to rely on inspection, percussion, palpation, auscultation, but also insonation is going to become a fundamental tool. Expert focused cardiac ultrasound in the hands of a cardiologist is a powerful tool that can enhance the clinical examination and increase the diagnostic yield significantly. And when we start to use ultrasound in a cardiology specific manner to look at other organ systems and other parts of the body, we can start to find, findings that are extremely pertinent and will change cardiology practice. And, with that, I thank you for your attention and I'll welcome any questions.
Thanks, Cvet. That was very insightful. So how about these devices, the echo ones?
Yeah, I think that's, fundamentally that's still a stethoscope. I think it's a useful tool. I don't think that, so some people might advocate that handheld ultrasound is going to replace the stethoscope, and I actually don't think that's the case, at least for now. I think the most useful way to use these techniques is in concert and in tandem. So I think as a cardiologist, you have significant physical examination skill, and you can start with your physical examination and then use the bedside ultrasound to clarify findings or to really hone in on particular abnormalities. I think electronic stethoscopes, are great educational tools, or maybe great for people who are a bit hard of hearing to kind of improve their auditory acuity.
Are you saying that I have a problem with my hearing? Okay, well, we'll keep that in mind. So you touch on a bunch of things. So and you briefly touch about the BNP and B lines. Is there a good correlation between BNP levels and B lines?
Yeah, I think a number of studies have shown that B lines really. First of all, B lines are not specific to pulmonary edema. B lines can also be seen in other conditions like interstitial lung disease. But in the appropriate clinical context, and there's other adjunctive lung ultrasound findings that can be used, B lines really correlate well with extravascular lung water and left ventricular filling pressure. So, B lines appear before patients experience symptoms of heart failure. And as the degree of pulmonary congestion increases, the B lines will increase and become confluent. And so, I'd expect that there would be a correlation with NT-proBNP as well. Yeah.
Okay. You did show also that there was a wide variability between, RVSI and these ultrasound measurements. What do you attribute that variability, and how do you compensate for that from the clinical perspective?
Yeah, that's a great question. I think, acute kidney injury is a multifactorial process. And, although renal venous congestion is one of the key pathophysiological factors in cardiorenal syndrome, it probably isn't necessarily sufficient in all cases to result in acute kidney injury. So there are some patients with renal congestion who are able to compensate. Potentially they have improved lymphatic drainage of their kidneys. And also, we don't have a perfect gold standard biomarker for cardiorenal syndrome. Acute kidney injury can be caused by other factors like acute tubular necrosis or renal, urinary obstruction. So acute kidney injury could occur in the absence of significant congestion. So I think the fact that we still see a correlation is really instructive. And I think this idea of coming up with a more precise grading system for abdominal or fluid overload using Doppler ultrasound is really starting to take off.
Okay. Now, I don't necessarily think that you need an echo to make the diagnosis of VFib, but having said that, you didn't mention maybe the potential use of ultrasound to target, for example, stellate ganglion blockade or cardiac sympathetic blockade for treatment of, ventricular tachycardia and VF storms. Have you used it at all for that indication?
Yeah, that's a great point. I thought of, there's so many potential uses for ultrasound in cardiology, and I think that's one that's really exciting and really applicable to the EP realm. I think, as cardiologists, procedural excellence is one of the techniques that we need to develop, and being able to guide a needle into a particular plane is definitely a technique that is significant crossover. But really, I think that nerve blocks are probably going to remain in the domain of anesthesiologists, who basically do this, in the perioperative setting for a living. With that said, I think stellate ganglion block is a really exciting technique in the setting of VFib storm. And I think, probably the way that I would envision that would be an anesthesiologist might be the one to do it. It's possible a cardiologist who's really proficient at needle guidance could learn to do stellate ganglion block using ultrasound guidance, but probably I think in anesthesiology will be the more likely service to perform that technique.
Okay, and so for maintenance of competency, how do you envision that? So what are the rules now? How is this going to work?
Yeah, I mean, I think that's a great question. I think, one can also ask, how do we assess maintenance of competence in physical examination? So I think one way that this can be done is I think through more regular use of ultrasound. I think if someone is to start to incorporate this into their regular clinical practice, then the skills will be maintained and developed over time. But certainly if someone attends just a one-off course and never uses the techniques, the skills will deteriorate over time. So I think it's going to have to be a combination of, deliberate clinical practice using ultrasound, and potentially, with workshops could be done in person or also online periodically to help people build skills in particular areas or refresh certain domains. Yeah.
Okay, well, thank you very much. I don't see any questions in the chat. Anyone has any comments? There's Greg raised his hand. Go. Yeah, Greg. Unmute yourself. Greg. Well, I think Greg wanted to say something, but there you go. We're having a hard time hearing you.
How about now?
Yep, we got you.
There we go. Great talk, thank you. Question for you: if you came across during your research for this or in your clinical emphasis
Yeah, no, you're like in the middle of a tunnel. We can't hear you. Greg, maybe try typing it on the chat, or maybe you're.
Can you read anything about use of those calculations?
Did you get any of that, Cvet?
No, unfortunately, I didn't catch that. Yeah.
Yeah, sorry, Greg. We didn't really hear anything.
Can you hear me now?
Yeah, you come and go.
Okay.
There you go.
Sorry, Cvet. Thanks for your talk. My question was, with increased emphasis of the use of right heart catheterization in patients presenting with cardiogenic shock to calculate things like pulmonary artery pulsatility index and cardiac power. Did you come across anything for the use of bedside ultrasound to estimate those calculations and avoid the need for an invasive right heart catheterization?
Thanks for your question, Dr. Schnell. So I came across this, I don't think there's necessarily a direct way to compare all of those calculations, but this paper was published in Circulation Cardiovascular Imaging, and it described a hemodynamic phenotyping using echocardiography for patients with heart failure that was based initially on an assessment of flow. So the stroke volume was calculated using left LVOT Doppler, and patients with normal flow stroke volume index, that is in this paper more than 30 mils per meter squared, subsequently had a diastology assessment. So patients were characterized then into normal flow and normal pressure, or normal flow with high pressure. And then patients with reduced stroke volume were subsequently characterized on the presence or absence of right ventricular dysfunction. So patients with low flow, no right ventricular dysfunction, and low flow right ventricular dysfunction. And this hemodynamic classification of patients with heart failure had significant prognostic value. So we can see normal flow, normal pressure, normal flow, high pressure, low flow, normal right ventricle, and low flow, abnormal right ventricle. So, I think this is, thought-provoking, and certainly the one thing that I think would need to happen to use echo as a hemodynamic monitor in the CCU would be a critical care ultrasound machine that allows you to really perform multiple measurements on a repeated basis. So, it's not just doing a one-off echocardiogram, it's rather being able to perform these detailed Doppler assessments on a repeated basis as hour to hour as you change your therapy in these sick patients. I think in the sickest patients, probably a right heart catheter is still going to be useful. But in patients with earlier stages of shock, maybe SCI class A or B, an echocardiographic approach might be a useful way to risk stratify these patients and to monitor therapies. I think it would be an interesting research project to compare the predictive value of echo hemodynamics versus those derived from right heart catheterization in the CICU.
So Hamid has a question, and there's something in the chat there. Cvet, maybe you look at it. Yes, Hamid.
Good morning. Can you hear me?
Yes.
Yeah.
Okay. Thank you, Cvet. Very interesting talk. Innovative models of care. I appreciate it. We struggle quite a bit at the college with regulation of these types of things. There are more and more individuals in different fields of medicine that are coming forward asking to do POCUS kind of measurements and outside the consultative realm. Do you have any sort of knowledge, experience in terms of what is happening down south in terms of the regulatory bodies looking at these things and finding a niche for them when it comes to kind of certification and maintenance of competence and all of that stuff? Because we are having a lot of trouble with it up here.
Yeah, no, I think that's a great comment. I think, bedside cardiac ultrasound has really exploded, and there's multiple disciplines who are performing this. The American Society of Echocardiography and the European Association of Cardiovascular Imaging both provided statements back in 2013, 2014. So these are guidelines that sort of delineate the scope of practice of focused cardiac ultrasound for non-cardiologists. And there are other documents that start to define like what kind of training pathways might be appropriate for these physicians. I think the critical care echo board examination is an important step forward. I think, ICU doctors have started to become quite advanced in their ultrasound techniques. So I think that's an important step forward towards accreditation. I've also worked in the emergency department. I've worked with emergency doctors, and they have echocardiography formally built into their emergency department training, but they're very careful about their scope of practice, and they use echo in a way that is well established in emergency medicine to make big decisions about, okay, does this patient have cardiac tamponade? Does this patient have severe LV dysfunction? So, I think it's certainly a challenge, but there are some guideline documents out there that try to make these delineations.
So how about Jeff's comment there on the chat? But
yeah, no. So Jeff Shaw asks, what is the appropriate scope of skills for cardiology trainees, and what would be required for training? I think the reality is that cardiology trainees are already starting to do this type of ultrasound assessment. People are starting to come through having been exposed to point of care ultrasound in medical school and internal medicine. And I think in cardiology, the formal echo training that we receive can really complement our ability to perform bedside cardiac ultrasound in emergencies or in clinic settings. So I think focused cardiac ultrasound is really going to be a natural extension of echocardiography training. I think what we need to build in more is some training on extracardiac assessment, probably focusing on the most high yield and most easy to perform techniques. So I think potentially integrating some lung ultrasound, didactic and training sessions would be highly pertinent. So yeah, I think probably we'd have to build on the formal echo training that we receive and incorporate some bedside kind of perspectives and also integrate some of these extra cardiac scans.
Okay, well, that was great. That was a great review and presentation, and thanks. And we will see you later.
Great. Okay. Thanks, everyone. Have a
Okay, thank you.
rest of your morning.